So today I will talk about management of Crohn disease. This is my disclosure of being a speaker and consultant for majority of the IBD pharmaceutical companies. So as we know that inflammatory bowel disease in general is a chronic relapsing inflammation of the intestinal tract. The main two diseases, ulcerative colitis and Crohn disease. In around 10 to 15% of patients, we cannot really differentiate between the two because of the way the patient usually presents. If we're looking at the incidence around the world for IBD in general, we could see that since the 1850, there was a steady increase in the ulcerative colitis, and it was mainly in the Western world. And from 1950, there was an increase in Crohn disease. But also in the last 20 to 30 years, there was an increased incidence of IBD in general in all developing countries, including our part of the world. There was a lot of talks, what could be the causes of the inflammatory bowel disease, a lot of work being done in genetics in the last 10 to 15 years. And we thought at the beginning, all the answers will come from genetics. So far, around 250 genes being discovered being associated with inflammatory bowel disease. Some of them were associated only with Crohn disease, like the NOT2 and BTBN22, and some of them are being associated with ulcerative colitis. But there was a lot of genes, mutations being found in both disease, at the same time being found with other immune-mediated disease and mycobacterial susceptibility infections. And this was explained, it's only the problem with the inflammatory bowel disease and the cause of the increased incidence was not caused only by genetics. Environment play a major role, microbial factors play a major role. And this has been shown that once there is any community, like our community, it changed their diet, and adapt more of the Western diet, more common diets, like the hamburgers and the fast food chains. This will lead to change in the microbiota of the population, and this may increase the autoimmune disease, and inflammatory bowel disease could be one of these diseases. If you look at the other inflammatory factors may play a role why we are seeing increased incidence of inflammatory bowel disease in our community. The main three things that affect usually Middle Eastern community is the smoking, antibiotics exposure in the childhood, and breastfeeding. You can see here from this slide that the smoking actually increase the risk of a Crohn disease, and we've been taught for a long time to actually decrease the risk or at least have a protective effect in ulcerative colitis, but this was not proven in patients with a Middle Eastern background like ourselves. Antibiotics usually have a protective effect. Antibiotics in childhood usually have a protective effect on the patients from Middle Eastern origin. This is for both ulcerative colitis and for Crohn disease, and of course breastfeeding. Other risk factors being described in different textbooks, like the oral contraceptive, appendectomy, low vitamin D levels, tea and coffee consumptions. It's even that it may affect the risk of ulcerative colitis and Crohn disease in different population. It's not been shown yet that affect the Middle Eastern origin patients like in our community. The main problem with inflammatory bowel disease, what we face usually in our daily practice, is how difficult usually to diagnose it. The main thing is difficult, if you can see here from the ECHO guidelines in 2018, that there is no single reference standard for diagnosis of Crohn disease or ulcerative colitis. So what we depend usually for diagnosis is a combination of clinical, biochemical, stool exams, endoscopic evaluation, and also with imaging and pathology. So we cannot really depend in one modalities to reach a diagnosis. This is make sometimes the diagnosis difficult and sometimes delay the diagnosis of both Crohn disease and ulcerative colitis. We can see here from this slide how wide is the differential diagnosis of inflammatory bowel disease and Crohn disease. With the ileitis and chronic inflammation, it could be an infection, especially in a society where it's very common, like our society. We have to think about all the times about infections, either as a form of gastroenteritis, parasitic infections, or sometimes even tuberculosis. For the ileitis, it could be affected by other gynecological disease like pelvic inflammatory disease, ovarian cysts, endometriosis. All these things could present with ileitis, so we have to be careful before labeling the patient with the Crohn disease. Medication could present us with a pictures similar to inflammatory bowel disease. This is both in the ileum and in the colon, especially the people who use high dose of non-steroidal anti-inflammatory drugs. Other form of vasculitis like Behçet disease and vasculitis in general like sarcoidosis could really affect the colon and cause inflammation there. Ischemic colitis sometimes present with a sort of colitis, usually could be easily misdiagnosed as ulcerative colitis, especially when it affects the left side of the colon and mainly around the splenic flexure in the descending colon. We try sometimes to get the diagnosis by using serological markers. The main two things being studied before an inflammatory bowel disease is the p-ANCA and the ASCA. As you know, p-ANCA usually associated with ulcerative colitis, and it have a positive predictive value of ulcerative colitis around 76%. ASCA usually more associated with the Crohn disease because of the low use of them clinically. We only use them sometimes when we want to differentiate between ulcerative colitis and Crohn disease in some of the patients who have indeterminate colitis. But usually we don't require them that much at this stage to diagnose inflammatory bowel disease. What the usual labs I order for my patient when I see them, what we usually do for them is the usual blood work like the CBC, looking for the mainly for the anemia, looking for their platelets. Also, as a sign when they have acute inflammation, will be thrombocytosis. We usually do comprehensive metabolic panels, and the main things we want to see here is the effect of the inflammatory bowel disease in the patient and their nutritional status. We look at their albumin, we look at their electrolyte, mainly potassium and magnesiums, and at the same time we do for them a complete liver function test, and what we look for is alkaline phosphatase, especially to rule out primary sclerosing cholangitis, which could be associated with inflammatory bowel disease and mainly with ulcerative colitis. Inflammatory markers are very important in, at the beginning of the diagnosis of inflammatory bowel disease. At the same time, they are really important in monitoring these patients and making sure that the patients be in remission. In the blood work, we do the ESR and C-reactive protein. We have to, I have to remind you here that around 10% of patients usually have a normal CRP, even that they have an active inflammations. And what you see with these patients, even when you diagnose them, and you know they have an active disease, when you look at their blood work is always within normal. These are the patients you cannot really rely on the CRP to see, to maintain, to make sure they are maintained in remission. I use these days the fecal calprotectin a lot in my practice. I use it mainly to differentiate between all sorts of inflammation, either inflammatory bowel disease or gastroenteritis, differentiating them from irritable bowel syndromes. These days, I don't usually do colonoscopy for diagnosis, except after I have a positive fecal calprotectins. And even after I start the treatment for my patients, I usually repeat for them the fecal calprotectin every 2 to 3 months to make sure that I maintain them in mucosal remissions. Stool assays is very important, especially in a part of the world like our part where very common rate of infection, either gastroenteritis or parasitic infections. We do it before diagnosing them with inflammatory bowel disease to make sure that we are not really mixing up with only bacterial or parasitic infections. At the same time, when they present with a flare-up after diagnosis, to make sure what I'm dealing with is an increased activity of the disease itself rather than a superimposed bacterial or viral infections. Endoscopy is very important tools for us to diagnose inflammatory bowel disease. And I really strongly advise everyone to do a full ileocolonoscopy for all patients being diagnosed with inflammatory bowel disease. Even that the patients I highly suspect of them having ulcerative colitis, I do for them a full ileocolonoscopy. I will take biopsy from the normal and the inflamed part, including the terminal ileum, especially the first times I diagnose them. This is except for those patients who present with very severe ulcerative colitis. I try not to do for them a full endoscopy when they are presented that times, just to avoid complication, either bleedings or perforations. When you look at the endoscopic features of inflammatory bowel disease, there is no single endoscopic feature that is specific for ulcerative colitis or Crohn disease. It's very difficult to differentiate between the two sometimes, but what usually we see that the ulcerative colitis, usually there is an involvement of a continuous superficial inflammation of the colon that starts usually from the rectum and extend to the sigmoid, the left side of the colon, and if it's extensive colitis, it will extend beyond the splenic flexures. With the ulcerative colitis, the main features suggestive for the Crohn disease, the main features suggestive of Crohn disease, usually the skip lesions, where you have an area of deep inflammation, including several layers rather than the mucosa itself. And between them, there will be a normal mucosa. These features is also present in other form of colitis, non-IBD, like vasculitis and ischemic colitis. So you have to be careful that you are dealing with a Crohn disease rather than other differential diagnoses. This is what I just mentioned before. You can see in these pictures in your left side, this is the superficial inflammation of ulcerative colitis, where there is a diffuse loss of vascular patterns. There is an erythema and edema and friability. With the Crohn disease on the other side, usually it's a transmural. So you see a deep ulceration affecting different layers of the GIT tract. There is a granularity and there is an edema and erythema surrounded by almost a normal mucosa. When you look at the histology, and this is one of the things that I see people sometimes confuse when they diagnose inflammatory bowel disease. Normally, there is always some element of inflammation in both of the colon and the TI, especially in the right side of the colon. So presence of a little bit of colitis or ileitis doesn't give you really diagnosis of inflammatory bowel disease. You have to correlate the whole picture of the patient rather than rely on the histopathology itself by its alone. And there is no histological features are unique to inflammatory bowel disease. I have to mention, especially that for the patient with ulcerative colitis, the things what I look for is usually the crypt distortions, which is usually the sign of chronicity rather than colitis or abscesses, because these things could present easily with any bacterial gastroenteritis and colitis. And I don't usually give the patient diagnosis of ulcerative colitis unless I see this crypt distortions and the sign of chronicity. When you look at the clinical pictures, this is a comparison between both ulcerative colitis and Crohn disease. With the Crohn disease, usually they present with abdominal pain, they present with diarrhea, nausea, and vomiting, and weight loss. When you look at the ulcerative colitis, they have sometimes abdominal pain if they have excessive colitis, but the main things usually bothering them is the bloody diarrhea and the rectal bleeding with the urgency. As we all know, ulcerative colitis usually involves the colon by itself, and the Crohn disease can affect any part of the GIT tract. We mentioned about the patterns, how we have a continuous inflammation in ulcerative colitis and skip lesions in Crohn disease. Rectal involvement is almost always there with ulcerative colitis. It's rare, it's also common with the Crohn disease. And the perianal involvement and the perianal abscess or fistula are not common with ulcerative colitis, but very common or roughly common with patients with the Crohn disease, around 10 to 20%, depending on different populations. When you look at the site of the involvement, the Crohn disease, 30% of them, they have a small bowel disease by itself. Ileocolonic, around 50%, and 20% of the patients have only colonic. And ulcerative colitis, you can see pancolitis around 30%, and 50% have left-sided colitis, and 20% they have it only in the rectums. It's very important to determine once you diagnose a patient with inflammatory bowel disease in general, and especially with the Crohn disease, to see what's the clinical pattern they have, these patients. Do they have inflammatory clinical patterns where they have an inflammation only to the mucosa and the submucosa, and these patients usually present with diarrhea and pain, and these are usually the patients will benefit from medications and you can really help them. There are some sorts of patients who have a structural disease. With these patients, there is hypertrophy. There is sometimes they present usually with an obstructing, small bowel obstructing symptoms. And these patients usually will not benefit from medication. What they really need, either surgery or dilatation through endoscopy. Fistulations, usually it's an aggressive inflammation, and they have fistula either to other parts of the GIT tract or to the other organ around the GIT tract. We have to understand that Crohn disease is usually a progressive disease. When you look at this graph, what we see here is the activity of the disease itself. So the patient, they will feel well for a while, and they have inflammation. Once you give them the medication, it will come down and they feel much better. Again, they will have another inflammation. You give them some medication, or by itself, it will resolve and they will feel much better. But we should not only look at their symptoms. What we should look is the structural damage to the GIT tracts. Once they have inflammations, then they go back to normal. Even that they feel better now and they have less symptoms, actually their GIT tract has been not back to normal. These are the people who have chronic inflammation. Then they will start having complications like stricturing, fistula, and they may need surgery in the past. So looking at the clinical picture by itself is not really the best assessment for Crohn disease activity in our patients. What we want to do, we have this windows of opportunity before the complication happened to the GIT tract at the beginning of the diagnosis of the disease, and we want to treat them at this times to prevent long-term damage to the GIT tract. This is the ideal medication where we give it at the beginning and we control the inflammation throughout their journey. This is the treat to target approach of monitorings. Once we diagnose the patient with an active disease, we risk stratify them and we give them the medication or the treatment plan we want to give them. Ideally, after 6 months, sometimes due to restriction, I would allow my patient to go even to up to 9 months. I would want to reach my target, and my target usually is the mucosal healings. And at 6 months to 9 months after starting my medication and treatment, I want to make sure they have no symptoms. I want to make sure there is no positive surrogate markers, mainly CRP and fecal calprotectins, and I will do for them endoscopy to ensure mucosal healing. If I reach these things, I will continue to monitoring them every 3 to 6 months, making sure there is no symptoms. I will do for them CRP and fecal calprotectins, and I will do the endoscopy for them every 1 to 2 years. If I don't reach my target, which is a mucosal healing and controlling of the inflammation in 6 months, these are the patients I will look again to to my plan. I will change the medication or I will add for them further medications. So what's I usually use is the 5S approach, which is if the first S is staging the disease, I stratify my patient, I set the treatment goals, which usually mucosal healing, I select the appropriate treatment, and I supervise the therapy for the patients. Before starting the best treatment for my patient, I have to define the location of the disease. For the ileal disease, this usually will benefit well by induction with the budesonide. For the ileocolonic and colonic, I may use systemic corticosteroid. Patients who have perianal disease usually will benefit better with the anti-TNF therapy. And patients with upper GI disease, they usually need biological therapy. Patients who have a short duration of the disease, they usually respond best to the biological therapy compared to patients who have the disease for a longer time. At the same time, patients who've been diagnosed young with the Crohn disease, they are the patients who they may end up with a complication in the future, and I try to be more aggressive with these patients than a little bit middle age or elder patients. And I define the dominant behavior of the disease itself. Medication work well with inflammation. When you have a structuring disease, medication will not work. So I rely a lot in the MRI. I rely a lot in endoscopy. If the main symptoms the patient have is small bowel obstructions, there is no benefit of giving them medication because most likely it will never work with these patients. And what they need either endoscopic evaluation with dilatation, or they will need surgery. At the same time, I exclude complication. I exclude superimposed infections. I try to predict my patients before I start the disease, which patterns of the disease they will have. Will they have an active disease at the beginning? Then they will resolve their disease. Will they have a continuous inflammation and continuous activity of the disease? Or they are the relapsing remitting types of the disease. Only small amount of patients who will have a very low activity at the beginning, and they will flare up a few years after follow-up. This is the usual risk factor for aggressive disease with the Crohn disease and ulcerative colitis. Patients who have extensive small bowel disease, patients who have an upper GI disease, a severe rectal disease, patient with perianal fistula, patient who present early with complication either with the stricturings or an abscess or penetrating disease, a patient with deep ulcers in the colon. These are the patients I worry about them, and I try to be aggressive in the management at the beginning of these patients. These are the medication, and you can see from this tables that I include both the ulcerative colitis and Crohn disease. With the steroid, it's usually good for induction of the remission, but it's not good for a maintenance of remission. With the steroid, with the Crohn disease, I usually prefer to use budesonide. The problem with the budesonide is the accessibility for a good percentage of our physician and patient. They don't have really a good accessibility for budesonide, but it's I prefer it rather than prednisolone if you could get it, especially for those patients who have an ileal disease and ileocolonic disease. Thioperin, like an Amuran, it's not good for induction, but it's good for maintenance. What I usually try to get for them is around 2 milligram per kg. I usually start low with the thioperin. I start with a 50, then I will see them every 1 to 2 weeks with a full blood work, LFTs and amylase, and I will increase the dose. Whenever I change their dose, I will do for them a full CBC and LFT and amylase to make sure I don't run up with complication. If you have the genetic blood work for them to see if they will have any side effect or bone marrow suppression with thioperins, you could do it. It's not available for me here in a timely manner. Patients who cannot tolerate thioperins, I usually give them methotrexate. For Crohn disease. For ulcerative colitis patients, I don't usually use it that much. The anti-integrins, usually the natalizumab and vedolizumab. Natalizumab, it's been only approved for Crohn disease. It's been taken out of the market only from a special patients. I usually reserve it for those patients who have both Crohn disease and multiple sclerosis at the same times. So I try to treat 2 diseases with 1 medication. Vedolizumab could be used for both induction and maintenance for both Crohn disease and ulcerative colitis. Anti-B40 like ustekinumab been approved for both induction and maintenance for both Crohn disease and ulcerative colitis, and I prefer to use it for those patients who have psoriatic arthritis or psoriasis, as I could treat the 2 diseases with 1 medications. At the same time, for both vedolizumab and ustekinumab, for my elderly patients, for my older patients above the age of 50, this is my I prefer these biological therapy over the anti-TNF therapy. Anti-TNF therapy, it's been approved for both Crohn disease and ulcerative colitis, the adalimumab, the infliximab, the certolizumab, and the golimumab. For only ulcerative colitis been approved. This is a good medication, especially for the patient with penetrating disease. You could also use it for patients with rheumatoid arthritis and uveitis. For the JAK inhibitors, it's only been approved at this time for ulcerative colitis, and it's also a good medication to be used and orally, and usually given for only rheumatoid. I prefer to give it for the patient who have rheumatoid arthritis at the same time and psoriatic arthritis, or those patients cannot really use an IV or sub-Q injection, and they prefer to take an oral biological therapy. It's very important to know that the timing of the management is really important. The best medication the patient will respond to is the first biological treatment you give to them. So the first biological treatment, try to use it wisely for your patient, because this is the best response your patient will have to the treatment. This is a slide showing a different type of biological therapy. We can see here with all type of biological therapy, whenever we use it in the early in the disease diagnosis, will have the best response, and the best response usually you will have it with the first biological treatment you give to your patients. I always, whenever I start the medications, I try to optimize the treatment for them. For the patient who've been in anti-TNF, I usually combine it with immunomodulator with the azathioprine. All we know from the SONIC trials, there was an excellent response when you add the immunomodulator to the anti-TNF therapy, and you have a better response for your medication. For those patients who have a perianal disease, when I start them with anti-TNF therapy, I usually cover them with antibiotics. My preferred antibiotics here is usually ciprofloxacin. I give it to them usually in the first 2 to 4 weeks of starting anti-TNF therapy to help really control their disease. If it's available for you, therapeutic drug monitoring is really important, and it will be it's a part of really optimizing the treatment at this times. I usually, for high-risk patients, I usually try to take the drug level at week 14 after starting the medications, and those patients with the low trough level, I usually increase for the dose for them, even that I didn't scope them yet to make sure that they have mucosal healings. We saw from the adalimumab, the patient, the pediatric patient in the BIORIS study, they really benefit from changing the dose and increasing the dose for them according to the blood level of adalimumab. And for 6 TG is also one of the things that's really important if the patient is failing immunomodulator azathioprine, to see what is the problem. Is the problem was mainly on adherence to the medication, or the patient is really not responsive to the medication. I match usually therapy to the disease activity. When the disease usually become active, I try to be more aggressive, and when the patient's disease usually come down, if I could, I will decrease the medication for them. I will end up again with the same slide I showed you before. Certify your patients when they have, make a plan for them, follow them during this plan. After 6 months, you should reach mucosal healing. At this time, they should have no symptoms, and their CRP and fecal calprotectin usually should be going back to normal. And I will do for them endoscopy if it's the first 6 months. If once my patient reach the maintenance phase and reach mucosal healing, I will see them every 3 months. I will do for them CRP and fecal calprotectin before they come to my clinic. Usually, I will once you do that, you will see an increase in the CRP and the fecal calprotectin usually 4 to 6 weeks before they have any clinical symptoms. These are the patients I will arrange for them another look for endoscopy. These are the patients I will increase for them their medication, or do the drug level for them if they are in biologics. Thank you for being with us. I hope everyone is safe, and I'm ready for any questions or comments from your side.
Thank you, Othman. It is very good, and you have many questions.
It's okay. It's okay. I love these questions more than sometimes the. So, do you want us to start from up or down?
Yes,
do you have the questions, Prof?
Yes. I want to start from up. So the first one coming from Bangladesh.
Okay.
That is speak about TB and the Crohn's. They have a problem on that.
Okay. So it's usually very difficult to differentiate between tuberculosis and Crohn's disease. There is a lot of, there's a few studies and a few guidelines being done trying to differentiate between two. I have to say, sometimes it's very difficult. Once I suspect it, I will take a biopsy for them. I will send a PCR for the patients. Usually the patterns of ulceration, usually either it's longitudinal through the TI or circumferential in endoscopy, give you sometimes of the hint. I have to say there is maybe 2 to 3 patients that I thought they have a Crohn disease, then they end up to be having a tuberculosis. But majority of these patients, usually they have tuberculosis somewhere else. So when you do the chest x-rays for them, before starting anti-TNF or steroid, you will see some sort of risk factor or a sign of tuberculosis. And when you do for them the quantiferon test, sometimes they are positive and you have to treat them. Sometimes when it's very difficult, I cannot really differentiate between the two. Sometimes I give the anti-TB medication for a few months and then scope them again. I don't really advise this is to be a regular practice, but sometimes, especially when a high-risk population, when they have a family or an exposure to the patient with the pulmonary TB, this is what I usually do.
So this is a good idea because this doctor from Bangladesh, so if you have a difficulty in diagnosis, he can start anti-tuberculous and then look for the follow-up. If it's good response, it's okay, and then you can look again because sometimes you cannot find all that. Second one, which is rectal involvement, is common.
Yeah. So what I mean here by rectal involvement, I would say that maybe I said common, but I think it's a little bit around 10 to 20% of the patients. I mean here mainly the perianal disease. When we look into our population here in Saudi Arabia, comparing to the other populations, we have more rectal involvement, more perianal involvement than the rest of the world. But I agree with Dr. Muhammad. I wouldn't say it's common, but it's around 10 to 20%.
Okay, the next one, you see it? When? This is a question which is coming every day.
So when to stop biological treatments? So
this is a very question which many people ask about that.
Yeah, so when we look at the de-escalation of therapy in general in inflammatory bowel disease, we do it all the times. When we give systemic corticosteroid to the patient, actually we de-escalate it after that in a while. When we give 5-ASA for a patient with ulcerative colitis, when the mucosa heal, we decrease the dose for them. So we de-escalate sometimes with the treatment of inflammatory bowel disease. With the biological therapy itself, usually what I tell the patients is I don't usually address the de-escalation except after 2 to 3 years of being in biological therapy. What I want to see at least 12 months of mucosal healing. And when we look at the data coming from Belgium, actually around 50% of the patients will have a flare-up in 2 years. And before I stopping the medication for them, I usually do 2 things. I will scope them. I will take a biopsy. I want to make sure that they have a mucosal healing in endoscopy. At the same time, I want to ensure that they have at least some histological healing, because I know these are the people most likely will never flare up. Even if they flare up, you could restart them in the same medication again. And it's not only the disease activity, it's also the patient factors. I try not to change a lot of medication for them if it's a very important time for them in their life. If they are just starting university, if they are getting married in the next few months, I don't think this is the time. When you stop the medication for them, then it really could affect their personal life or their professional life. So I usually try to address this patient by patients, and hopefully in the near future we'll have more guidelines to address this and to see what will be the best way of starting or stopping the medication for them.
For me, it is the same. If you give a treatment, a biological, and the patients become in 12 months very good. Endoscopy, healing of mucosa, everything. And you said that if you stop and you go down to 5-ASA or you go down to anything else, it's flare after 2 years. And then you can then start again biological treatment. This is happen.
Sometimes I do this. Sometimes when they flare up, I restart them again. One of the other things maybe I forgot to mention is I do for them the blood level for biological therapy before stopping them, stopping the medication to see how much if they have any antibodies. And if we see from the Leuven experience, there is around 70% of patients when you restart their biological therapy, usually they respond again to the biological therapy once you restart it again after a drug holidays.
Okay, the next risk factor you consider during your clinical practice.
So the risk factor for, I think what you mean by this question is the risk factors for a bad prognosis for the patients. I think I mentioned it in one of the slides. Patients who have extensive perianal disease, patients who have an upper GI symptoms, patients who are usually young, who present with complication, patients who have a deep ulcerations during endoscopy and Crohn disease. These are usually the patients I worry about them, and I try to advance their treatment to biological therapy as soon as I could.
There is one question, which not question, but coming from chat, from Siberia. From Siberia. You know somebody in Siberia?
No, I know. No, this will be the first one.
We can speak later on about Siberia. Because somebody, I don't know it's a man or female. The other one, what's your opinion how to make use of the window opportunity?
So what I meant by the window of opportunity, I mean those the patient
mucosal healing.
Yeah.
So let's start by one.
Yeah. So for the window of opportunity, if the patient is declaring himself from the beginning of the diagnosis, they present all the risk factors for the deep ulceration, when they present with complications, when they present very aggressive disease, most likely these patients will not respond only to a steroid induction, then immunomodulators. These are the patients where I know 1 year or 2 years from now, they will end up in biologics. So for those patients, why I'm waiting for them at this time, not giving them the best treatment I have, and I give it to them in the future. So these are the patients I try to introduce the biological treatment for them earlier in the disease, if they declare themselves from the beginning. One of the things I always say for us as a gastroenterologist and IBD specialist and biological therapy itself, if biological therapy were as cheap as 5-ASA, I would believe that 80 to 90% of all of our patients will be on biological therapy. The main things why we're restricting the use of biological therapy for our patients is the economic and the price. So for those patients, I know they will need it in the next futures. These are the patients who I will start the medication for them earlier.
So what's about fecal calprotectin and mucosal healing?
So the correlation with the fecal calprotectin and the mucosal healing, usually they correlate very well. It's not 100% accurate, but it's really very good accurate. The best way of looking at it is for ulcerative colitis, we know from the CALM trials, we want the key fecal calprotectin to be less than 250. And for Crohn disease, usually I like it to be less than 100. And the main things I think we should look at, it's not really a specific number for all the patients, but I compare the patient himself. When he was active, what was his fecal calprotectin? And at this time, what is his fecal calprotectin? When I first diagnose them, I do for them fecal calprotectin. For them, it's like 300 or 400. And after 6 months is 50, I really not worry about this patient. I know this patient must likely have a mucosal healing. If the patient, when I start diagnosing them, the fecal calprotectin was 1,000, and after 6 months is 150, I know I made a good progression in treating this patient. So it's not a one value for the whole patients, but usually depending on the patient, I compare the result of the patient from one time to another.
There is one cytomegalo infections. Do you restart biological?
So when I suspect cytomegalovirus infection, especially if the patient who's been immunocompromised or immunosuppressed, patients, I will take the biopsy, look for the PCR, I look for including bodies in the histopathology. I will do for the antigen for them, and then I will wait for these patients till I treating them. Once I think the response and the antigen in the blood really decrease down, this is the times I restart their biological therapy, and I usually have a very close consultation with my infectious disease specialist in these cases.
Okay, can you tell us if you have any experience of tafasitamab in ulcerative colitis?
Tafasitamab?
Yes.
So tafasitamab, I have some experience with it in ulcerative colitis
It's a professor from Europe, I think so.
Ah, okay. So I have some experience. I don't have it that much. It's been approved only in the last, I would say, in February. So just before starting of the pandemic in Saudi Arabia. It's a good medication. It's usually work well for those patients who's not really responding well. I worry sometimes about this medication, about infections, and also the thromboembolic side effect, especially when you use 10 milligram dose. This is the main things. I have a few patients who need it for different indications, and they have Crohn's disease at the same times for the last maybe 3 to 4 years, and they're really doing well in tafasitamab. But this is my experience with it.
There any time for RIS or BH dependent 5-ASA and Crohn's disease?
So with the 5-ASA, I don't usually use it with the Crohn's disease patients. So except some limited patients, when they have very mild colonic disease, I will give them some 5-ASA. But patients with the TI disease, with terminal ileum, with the ileocecal, I don't give them really any 5-ASA. I inherited some patients from different physicians who've been in 5-ASA for a while. If they are doing well on it, and sometimes they are psychologically attached to the medication, I try not to use it. But I don't usually use 5-ASA in management of Crohn's disease, except very few patients with the mild colonic disease.
What is the best term of efficacy in Crohn's disease? This is a company question that will come from where?
What's biologics the best in terms of efficacy? I think it's depend. I mean, I don't think there is no single study being done from comparing biologic to biologic yet. There was a small study looking at adalimumab and vedolizumab, but I don't think there is one biological therapy is superior to another's. I would look at the other factors the patients have, their age, their comorbidity, if they have any other external manifestations, or they have any other disease, as I mentioned in the table. This is the factors usually affecting my choice, and also the patient's preference. Does he prefer to be in an oral? Does he prefer to take an IV, or he prefer to take a sub-Q medication? These are the things I'm looking at. I don't think we have enough information at this time to say this biological is better than the other biologic.
Role of any immunomodulators was biological?
So I mentioned this a little bit late in my presentation. When you look at the SONIC trial, using immunomodulators with anti-TNF therapy usually really help reaching mucosal healing. It was and the response for both in Crohn's disease in the SONIC trial and the successor trial in ulcerative colitis. And it's not really well understood, but it seemed to be increasing the drug level in the blood. So I use it when I use anti-TNF therapy for my patients.
Yes, you can use biological early cases.
So early cases, if you mean by early cases is just being diagnosed, I would rather look at the risk factor for the patient themselves. Do they have a risk factor? Will be most likely these patients will end up in complication in 1 or 2 years. These are the patients I usually start in biologics. Rather than looking at early, I think that's what he thought, or that's what his questions was about.
Because Dr. Othman, there is some people said that when you have an early ulcerative colitis or Crohn disease, you can start by normal drugs and safe. The biological will become more fluid. But you think that we can start from the beginning, so you can maintain? This is a question everywhere now.
Yeah, but as I mentioned before, I mean, I think the main things is, could we afford this? I mean, it's not a cheap medication. It's very costly. The main costs right now from biological therapy and IBD in general throughout the world, in Saudi Arabia, and when we did a study we published lately in the last 2 months, in Europe and the States, the main cost in the management is the medication, the biological therapy. If they were a cheap medication, I think maybe we'd use it for majority of our patients, but it's not really a cheap medication. And sometimes our patients, they don't like to use it for a long time. And we have to keep in mind this medication doesn't work all the times. There is some percentage of our patients, they lose the response in a few years. So I rather use it for them in the right time rather than using for them early or late. I rather use it for them in the right time when they need it.
Okay. Steroid in COVID pandemic.
So steroid, when you look at the COVID infections, one of the main things that increase the risk for acquiring COVID and for a bad response or a bad prognosis when you see COVID is the use of systemic corticosteroid. So I try to avoid using it as much as I can for our patient in these times.
This is a nice question, which I think you see it. What do you mean by indeterminate colitis? This is a many pathology come with these patients complaining. You take biopsy, you find very simple like chronic mucosal congestions, and you take biopsy and the pathology come like that. What you do?
So in these patients, the good things about indeterminate colitis, when you cannot really differentiate between Crohn disease and ulcerative colitis, the treatment is almost the same between ulcerative colitis and Crohn disease, except for surgery. These are the patients, if I'm not sure, these are the patients I try not to send them for a total colectomy. For sure, I will not do for them an IBAA, a pouch procedures before making sure they don't have a Crohn disease. But the other medical treatment is almost the same. I mean, majority of the medication that respond well for in Crohn disease, they also respond well in ulcerative colitis.
But again, Othman, many people come with mild symptoms, and you do colonoscopy, and you found small congestions, loss of capillary patterns, vascular pattern. You take biopsy, and the report coming like that.
Yeah.
So this is inflammatory bowel disease, or this is you should treatment. What we can do? He's complaining, has a minimal things in colonoscopy, but this is a pathology coming.
Yeah, so what I usually do with these patients, I do for them fecal calprotectin at the baselines just to see what's the level. And there is a good percentage of my patients who present like this. I give them 5-ASA only. I give them 5-ASA, then I follow them up with the fecal calprotectins. I compare them with the first one to see if there is a response or not. Sometimes these things happen because of different things, either because of medication, ischemic colitis, endometriosis, or even a very mild inflammatory bowel disease, a very mild Crohn disease or ulcerative colitis more commonly. So these patients, I usually treat them with only 5-ASA, either orally or rectally, depending on which side of their colon has been affected. And I follow them up with fecal calprotectin. And also, of course, symptomatic wise, if there is any response.
Also, another one which I think is very good imaging modality for upper Crohn, because there are many studies about now sonography for that and MRI, and there is many papers about sonography.
Yeah, so with the image modality, what I usually use in my practice is usually MRI. I wish I have a specialized and a good ultrasound IBD guy, but it's need really at this time needed trainings, and we don't have someone in our centers yet. But I really advise anyone who want to get better on it, and or to recruit someone who will do these things, because I think this is the future for inflammatory bowel disease, is the ultrasound for IBD for diagnosis or for to assess the response to therapy.
But what's your idea around the world? If you give advice, is sonography or MRI?
If you have sonography, do sonography. It's easier. It's usually done in your office, and especially if you can rely on your results. If you don't, I would rather do MRI rather than CT scan to decrease the exposure. But ultrasound, I think this is a future of inflammatory bowel disease. And if you have an access to it, please do it.
Okay. Would you like to take some rest?
No, I'm okay.
Azocyprine, you can use it to maintain.
So the question is, do you use it for maintenance according to the age, regardless of the age? Usually azocyprine, I try to avoid using it in elderly or elder patients. Sometimes in a young also male, because this may increase the risk for lymphoma and hepatosplenic lymphoma. Young male, I don't usually try to use it for a longer times. But other than this, I use it for maintenance.
Okay, the second one, perianal management.
Perianal Crohn disease is usually very difficult to use. The best medication for this disease, disease usually is anti-TNF, mainly IV anti-TNF, with the use of antibiotics in the first 2 to 4 weeks. I find my patients respond much better to this medication.
The next questions, I think you answered it, and will be about how to start with mild and moderate Crohn disease. You started. Patient azocyprine, you recommend that you go to dermatologist?
So in our area, we don't have that common dermatological malignancy like the Western and Caucasians. I'm sure it's the same for you, Dr. Brahim Mustafa, in Egypt. So in Saudi Arabia, it's very rare to have dermatological malignancy like melanoma or squamous cell carcinoma of the skin. So we don't usually have this problem in Saudi Arabia. So I don't usually do it. Looking at the data from North America and from Europe, the risk is higher, and I think the patient should be tested according to their guidelines. But in Saudi Arabia, we don't have this common problems here.
I agree. I have many patients with azocyprine and no problem. In the dose of biological, reinitiate, or you keep the maintenance dose?
In case of the service biologic, so usually I reinitiate if they are being for a long time, more than 2 to 3 months. I usually reinitiate for them. If it's only like they miss their dose for 2 to 3 weeks, I continue the maintenance for them.
This is a question which is coming now very common during COVID area. When you have a disease IV, you change by subcutaneous, or you have a new case coming to start by subcutaneous for delivery at home instead of going to the hospital. So this is a question now about IVB or subcutaneous.
So IV, subcu, or oral, I think this is depending the availability of the resource you have in your clinic. At the same time is your patient's preference. Some of the patients, they prefer to take an oral medication. Some of them, they prefer to take an IV. And some of them, they prefer to take a subcu injection.
There's another question, beyond, if you have a case simulating IBD, especially during pandemic, we face many big pediatric cases during the period, even stimulating Crohn disease. This means that there is, I saw many cases like that also. Not COVID, but I have many cases coming now with COVID with the symptoms like IBD, especially children diarrhea, gastric pain, something like that. What you do?
So whenever I see a patient,
you have some cases like that already or not?
So I have some of the cases these days happening. I'm not sure if it's a COVID or an IBS because of the stress we have, all we have these days. But what I usually do with these patients whenever I diagnose them, or if they've been known to have a Crohn disease or ulcerative colitis and they present again to me, I have to make sure they don't have an infections. So I don't usually run to start these patients in steroids or giving them biologics. These are the patients I try to calm them down with the antibiotics if they have diarrhea. I will take my time to diagnose, but I will not jump immediately to give them a steroid or something in the clinic from the first times I see them, even if they are known to me to have Crohn's disease for years. I have to make sure there is no infection, there is no C. diff. I prefer sometimes to do for them a sigmoidoscopy, take biopsy before starting any steroid or biological for these patients.
I agree, because I present the lectures about that also, that during mass endemic, you should not starting with the with biological, because you can wait 2 or 3 months. It's come by normal treatment, and if the patient's on IV, it can be shifted to subcutaneously. And if you start, we are obligatory to start a new one. It should be subcutaneously. So, how many patients of Crohn's are you only on IMM?
So, how many patients? I mean, if you need my practice, it's usually different from one practice to another. Because I work in specialized centers, I usually see the difficult cases, so I have less than the other people. What I would say, it's similar to the other treatment. Use the least medication that keep your patient maintain and mucosal healing and good quality of life. In my practice, I would say maybe 10% of my patients is only immunomodulators, but my practice may be different than other people practice. I work in a specialized centers, and I usually around 95% of my work is inflammatory bowel disease and difficult cases. So I see more patients in biologics than only in immunomodulators.
What the use of biosimilar instead of biological?
So the biosimilars are biologics at the end. So depending on what do you have, what's been available for you, I think it's the same. I think the dangers we have at this time is switching between different agents. You start with the biosimilar, then you go to the original, then you go to another biosimilar. I think this is the dangers we have right now, just because we don't have an evidence yet. But if the only available for you is biosimilar, I don't see any reason why not to start in biosimilar. Whatever available for you, whatever your patients could afford. And especially these days, I think the price difference between the biosimilar and the origin is not that much difference, at least in our area. And even majority of Europe. I don't know about Egypt and other countries, but I don't think there is a price is much difference. Whatever available for you, use it, but try not to change the agents you have from one week to another.
Okay, duration of maintenance.
So as I mentioned before, usually maintenance I use this for 2 to 3 years. Then I discuss with my patient if they prefer to stop it.
There is duration of induction.
Mm-hmm. The duration of induction therapy. So induction, it's usually depend on the agent you're using. Either using infliximab, usually 206. If you are using adalimumab, it's 028. Depending on the agent you are using. So the induction until I control the disease and I feel the patient is their symptoms being controlled.
Okay, there is another two, because there's one from me and one from. What is the histological scoring, if you prefer, from practical and the clinical perspective?
So there is the main score I think we are using these days is the Roberts scores, which was actually published by our dear friend and colleague, Dr. Mahmoud Mousali from Jeddah. I think this is the things that we are using mainly those times. For the clinical work, it's not been adapted in the all guidelines yet, because we cannot reach the response in majority of the patients yet. In the futures, we will see more and more of these scores to assess the response of our patients. But Robert's scores is the things I usually use in my practice.
Okay, for me, another question. If you have a patient which is using biological, using also with him also Murine, and he's a young who's Crohn's, typical of Crohn's disease, and they shift from corticosteroids to Murine, and then pentazan Murine, and then biological, and he's in biological since now or around 1 year, but he's corticosteroid dependent. If you decrease the corticosteroids to less than 10 milligrams or 20 milligrams, he become again beta. So what you do for this case? Shall you shift to another biological, or what you do? He's totally dependent on corticosteroid.
So if they cannot stop the steroid itself, that means the biological most likely it's not really working. I will take the drug level of the biologic in the blood to see if the therapeutic or not. I will take antibiotics to see if there is a response to it or not. But clearly, if they're
he received antibiotics for 2 weeks.
Yeah. So clearly he's not responding. And for these patients, do they have an antibodies against the medication or not? If they have an antibodies against the medication, you could shift them to in the same class. If they have no antibodies to the medication, to biological therapy, that means the patient need to shift to a different class. So from anti-TNF to anti-integrin, or from anti-integrin to secukinumab. So depending on what they are using, and if they depend on the drug level and the antibodies against the medication. But clearly, if they cannot decrease it, that means they are not responding.
This is very good. And you have in Saudi all the antibody and measuring of all the drugs in Saudi?
So it's available for us, but it's usually done in to be sent in a lab in Germany, and there is another lab in Dubai. They send it to be done. It's not been done locally. We can do anti-TNF locally here in some of the centers, but majority of the blood work will be sent, I think, for I believe to Biosentia in Europe.
Because there are many cases now. I face some of these cases now, and to shift it from 1 to 1, you cannot do that without measuring that. Yeah. And you cannot do what you can do for the patients. He asks you, so you should measure the drug level and the antibody for any drugs before shifting. Yeah. And if you shift from 1 to 1, you shift in the same class or in another class of drugs.
Depending on the antibodies. If there is an antibodies, you could shift to the same class. I prefer usually now, because of availability of different class, to shift to a different class. But for sure, if there is no antibodies, they have to be shifted to a different class.
To a different class. Yeah. Very, very good. So I think now, if you have any comments, anyone, because now we finish 100 questions, and you are so tired. People ask you from everywhere, from Bangladesh, from Egypt, from Saudi Arabia, but something from Siberia, which I don't know who is this. Well, thank you very much from Siberia. I will discuss with you about Siberia later on. But this is all the questions coming for us, hundreds of questions, hundreds of chats. I think you got a very nice presentations. Also, your answer for all the questions are very in point, are very straight, and this is experience, or this is in my experience, that your level in IBD and ulcerative colitis is huge. I myself get something new for me from you. I learned something. So I thank you for your level, for your experience, for your sharing with us, and we hope we're sharing in another activity by another means, and we will get you to many things for that reasons.
Thank you, Prof. Ibrahim Mustafa. If you learn a few things from us, we learn huge things from you. Not only me, majority of the gastroenterologists throughout the region here, you've been a determined force for gastroenterology. You inspire a lot of gastroenterologists through our region and throughout the world. and your training center is really bringing a lot of gastroenterologists in the developing countries up to the par with other European and American countries. We thank you for your inspiration for us for the years, for preparing the new generation of gastroenterologists to be a great gastroenterologist like you. Thank you very much for having me today. It was my pleasure being with you today.
Okay, see you very soon, either on live, face-to-face, inshallah, very near. And I think you, as you said in the beginning, before the study, when we start face-to-face, we'll start face-to-face very near. Believe me, very near. In September, we'll be in face-to-face, and also in December, sure, we will be face-to-face in Egypt GastroHub, maybe by a new idea, according to the company. Maybe I do it in Garda'a or something like that. But I should see all my friends or my colleagues and everyone. So enjoy your time.